Everything rises and falls on leadership. The ability to lead well is fueled by living your cause and purpose. This podcast will equip you with the tools to do just that. Live and lead with cause and purpose. And now, author of the book, The Anatomy of Leadership, and our host, Chris Comeaux.
Hello and welcome. I'm excited today. Welcome to our TCNtalks Anatomy of Leadership podcast. My good friend Cordt Kassner here with me. Welcome, Cordt.
Thanks, Chris. It's great to be back.
It's cool to have you back. And so just to maybe refresh our listeners, because they're like, you guys had a rhythm in 25 and you've done something different in 26. So just a review, Cordt and I kicked off the beginning of the year, top news stories of the month. We did our predictions for 2026, which at the end of the year or beginning of next year, we'll actually come back and see how we did. Some of which, Cordt, you're probably like, hey, I'm doing pretty good. There are a couple I'm like, I did pretty good. I'm like, gosh, I missed that one.
It's fun to track it throughout the year.
It is fun to track it. So what we've done is we kicked off the year that way. And then one of the things that Cordt and I, as we brought Dr. Bayak at the end of last year, is a gift to all of our hospice and palliative care listeners, people doing the real work on a day-to-day basis. Cordt and I had this idea afterwards and said, what if we use Dr. Bayak's framework, his strategic framework, to drive our conversations throughout the year? And so that's kind of what we've been doing. You may not have realized that. So we kicked off January, and then we're bringing outside speakers that put meat on the bone related to Dr. Bayak's framework. So the measures that matter, we actually had Bob Tavares, Robin Heffernan, Mindy Stewart Coffey. They were part of the Measures That Matter initiative with Bob. And that was all around standards and quality and data. So you can see how that connects to Dr. Bayak's framework. And then we brought the Jerapal guys, actually, which was kind of cool. It was a podcast within a podcast. And we did use Dr. Bayak's framework. Of course, they asked some questions as well. I got to talk about leadership. Anytime I get to talk about that, that's pretty cool. But then each beginning of the quarter, so this is top news stories of March airing in April, Cordt and I are going to come back and do what we did last year, which is top news stories, but we're going to do it over the quarter. Now, do not lose sight. Every month, Cordt and I are actually including links to, he's got his data, and I've got the articles that I'm flagging as Chris. So what I'm going to do today is I'm actually going to look back over the last quarter, the ones I wanted to highlight, and then Cordt's going to do the same and talk about some of his stats. So Cordt, do you want to talk about your stats first, and then that'll give us a good jumping off point where we could kind of go into, then we'll do mine, then we'll do yours. Sound good?
Sounds perfect. So here we are in March. This is like people coming out of hibernation is what it feels like. Spring is here. It's been amazing. This month was really nothing short of remarkable in terms of hospice and palliative care today readership. We released 294 articles, which is pretty normal, that collectively drew 170,000 reads. And the last couple of months, we've been averaging around 105,000. So this was a huge jump. And some of that has to do with the content, the MedPAC report, the Alliance releasing facts and figures, which were our top two most read stories. But still, it was a huge jump in the number of reads. Even more telling, we had 62 individual stories. Each surpassed 1,000 clicks, twice as many as last month. So this surge signals that certain topics are hitting home with you, our community of providers, clinicians, policymakers, and advocates. We're also thrilled to announce that our subscriber base has grown to 2,400 readers. So thank you for being part of this vital conversation. Whether you're at the bedside, leading a program, or shaping policy, your engagement helps us move forward. And please encourage your colleagues to subscribe to Hospice and Palliative Care Today. It's free. It's a daily environmental scan of what's going on in our field.
Well said. And congratulations, Cordt. I'm not surprised you keep doing the right thing, and I think you're going to keep gaining traction. And so hopefully not too distant future, you'll see 6,000 plus subscribers, which means on average, you'd have about one per every hospice agency throughout the country. So,
exactly.
All right. You want to jump into mine?
Please.
Yeah, so let me just give a quick flyover looking back over the first quarter. So January, I flagged 56 articles. February, I flagged 54 articles, and then March, I flagged 39. So no deference that, oh, well, gosh, those seem like lower numbers. I'm just trying to be more discerning of what we actually bring to our listeners. So the vast majority I'd like to highlight is coming from March, but there are a few I wanted to go back into in February and January. So let's pull from March. This was a New York Times opinion piece. A lot of people reached out to me like, what are you going to do about this? It really, and first off, I mean, kudos, because it was from someone it was a guest essay, someone who just experienced hospice. And here's just a quick excerpt. When my siblings and I decided to put our father in hospice at his home in the spring of 2021, his Alzheimer's was near end stage. He could barely get out of bed, dress, or feed himself. Hospice care seemed to be the best way for him to end his life with dignity. We soon encountered a harsh reality, however. Dying at home isn't easy, even with hospice care. The main problem was funding. In 2024, the average per patient Medicare payment was about $200 a day with an annual cap of $33,500. The outlay would barely pay for a part-time aide, yet is also needed to cover medications, medical equipment, and nurse visits. So it really did kind of point to the original vision. Cord, even the logic behind the actual reimbursement was not even to reimburse us for things like volunteer coordination, bereavement care, the methodology by which it came, and certainly has not kept up with inflation, especially the last 5 years, as we've been in, I won't call it hyperinflation environment, but certainly much higher inflation than we experienced at least prior into my career. And so it's not kept up. And then this family was just lamenting. It did have a tinge, and I can't wait to hear your feedback too. And I kind of thought hospice was going to take care of everything and didn't realize how much we were going to have to do. And that's interesting because, the model has always been about empowering the family and the caregivers to being a comprehensive model to doing that. And here's why it's a little concerning to me as we go more into the baby boomers. Are we going to encounter more of, well, this is what our expectation and this is what you guys are about. We thought you'd just come in and take care of everything. So do we have an expectation gap between what's now becoming the sandwich generation, and then the sandwich generation is even going to become some of our patients going forward as the baby boomers age out more and more? And recently, my father-in-law had a pretty serious health circumstance and just is giving me a front row seat. Thank God for my wife, who has stepped up in a beautiful way for her dad. That's the family member. And I was thinking, man, a lot of families don't have an incredible caregiver to stand in the gap as we go more into the baby boomers. So I feel like there's some storm clouds that are kind of been unearthed in this New York Times opinion piece. Funding has not kept up with the model. Is the model keeping up with what the expectations of the baby boomers are going to be? Now, I'd also kind of push back on myself. I still think hospice is one of the most brilliant models of healthcare ever devised. And when it is deployed well by a high quality program, it does amazing things. So I'm not ready to throw the baby out with the bathwater, but I think it raises some interesting questions.
I agree. And as I reflected on this article, it really made me think about the two sides of the coin. Hospice, one side of the coin is that hospice is the gold standard of end-of-life care. There's no doubt about that. We do more, better, more comprehensively, interdisciplinary team. We set the stage for difficult conversations and do things that the rest of healthcare it kind of lacks. And for that we can stand in the sunshine and pat ourselves on the back, and this is a good thing. The other side of the coin is I had an experience with hospice last year when my mother died, and it brought home some of the gaps in care that hospice. On one hand, there are gaps that hospice says it does and it doesn't, and there are just gaps that it was never really intended to cover. And so we see the growth in caregiving and doulas and palliative care and these other areas that complement and come in and help fill gaps that hospice doesn't do. So it's really looking at both sides of the coin. We're so appreciative of what our hospices do for half of dying Americans across the country. And on the other side, there are some gaps. And across the best hospices, there are gaps in care that really lean on the family members and external caregivers to fill those gaps. And this article, I think, obviously this was leaning on the gaps side of the coin, But we need to hold both in tandem and figure out how we can continue to do this better.
You think, Cord, those gaps, I'm kind of inferring so you push back if you disagree. Is that gaps mostly the fact that it's not there really someone 24/7 supporting, the caregiver themselves, maybe 88 and the patient much older? Or are there other gaps that you're alluding to?
I think there are other gaps, but I would, in a general way, frame it around setting expectations. That at the admission process, we are going to be here. Again, I will use my own case example. My mom was in general inpatient care for 20 days, and I was told numerous times, we will be there when your mother dies. If you're not there holding her hand, we will have somebody there. No one dies alone. And so that expectation got set. So when she died in the middle of the night, on a weekend, of course, guess what? She just passed during the nurses' shifts, during rounds, and there was nobody there. And some of the other services, the volunteers, the social work, the chaplain was kind of an interesting story, missed the expectation that were set. The nurse was amazing. And I'm not complaining about it. Because we're in the field, like we have conversations with all of these folks. But when I talk with other people who've been in hospice for decades, my experience is very, very common that the actual care and service that was provided missed the expectation of what we thought was going to be there.
And kudos for you thank you first off, because now I feel awful as your friend. I'd never pushed in further. You've alluded to it, and I felt like it was a sensitive area. There is something interesting in a podcast with, actually it was in the green room. It wasn't the podcast itself. One of our well-known folks, I'll leave her nameless, but well-known person who's been in hospice from the very beginning, said in the early days, we debated, there's literal meetings. They were throwing chairs at each other because they were so passionate about the debate of what we do. And then the fact that Dr. Byack says that collegiality ends at criminality is kind of an interesting commentary of where do we lose the ability to have a frank conversation with each other? It's which I think is probably also the spirit of the age we live at the time. What corner are you, red or you blue, whatever. But I love the fact that you just say there's something we should be talking about. And there is the SIA. There's no more data now telling you we're in that window. And so it's either well, is your hospice perfect or is your hospice totally crappy? There's stuff in the middle that if we have good debates and conversations, it's going to ensure that we keep doing better. And, I'm sorry to take it back to Dr. Byack, but I really feel like that's what he's poking on, is to say, hey, I'm worried about this stuff. We should have frank conversations. So kudos to you for bringing something up that I think you're inspiring me to kind of take that even back to the hospices we work with and say, how are we doing with that?
Yeah, when we got involved in hospice years ago, I remember saying over and over, hospice is 95% angels and 5% horrible. Not that hospice is horrible, but the situations are untenable. Mm-hmm. And now, again, based on my experience, but talking with so many others, there's a pretty big percentage of pretty okay hospice.
Yeah,
it's pretty okay. It's not golden angels. It wasn't horrible. And I don't even know how to put a number on that, but that segment never used to exist. And now it's I think a pretty substantial part of the equation.
And I've just gotten reintroduced or just become more passionate about Jim Collins again, and he's actually releasing a new book. I was actually part of a group that got to hear his unveiling and talk about it. But it's really what he was poking on with Good to Great, is that good has become the enemy of the great. I wonder if we've kind of fallen into that we've heard we're angels for so long. But then we've also had these horrible fraud situations in California, which is not even in the same realm. Like what you're alluding to ain't that, because that shouldn't even have the name hospice, some of that stuff. So that almost becomes a distraction, but then unfortunately it becomes part of the national news. Are you kidding me? There's 100 licensed agencies as one address in California. And that becomes sensationalism. You're damn right that should be fraud. It should be called out, because this is really the stuff we should be talking about, of really becoming great as we go forward.
Absolutely. Well, we've got a lot of ground to cover, but I think this was a really important place to start.
I agree. And again, thank you. And my apologies to you and your family. So the next one I'm going to call out, Cord. The U.S. healthcare spending problem is still about prices. This was a Health Affairs article. And just lamenting, it's the prices, stupid, is basic one of the taglines. Central insight remains true today as it was when it was first articulated across services, drugs, inputs. The United States consistently pays substantial higher prices than its peers for comparable services, drugs, and inputs. This harkened me back to our podcast with Rita Numeroff last year, and I gave her the microphone and said, hey, RFK calls you. How would you fix it? This was part of her key platform, if you will, of how you fix healthcare. And you may go, what do we care as hospice people? Because we exist in a broader system that's pretty screwed up. And as we try to fix the broader system, I want to make sure we don't get impacted as the whole Titanic gets reshuffled and then we get impacted because we weren't part of the conversation because they're like, well, you guys need to fix all of healthcare. We got the hospice and palliative care thing, if you will. There's a great, in fact, we might even include a link. I love the healthcare A to Z guy. I wouldn't even call them their podcast. They're like little 10-minute educational videos. And he goes through the payer mix of the vast majority of especially healthcare systems. And why does it matter? So here's kind of the punchline. Usually they charge ballpark 400% of Medicare to the commercial insurance companies. Medicare, maybe you're about break even, and then Medicaid, you're in a loss situation. And you make it work because of the markups on the commercial insurance that they negotiate that. And then they're kind of okay with the Medicare and they don't like the Medicaid, but if they're a nonprofit healthcare system, they serve the community. So they accept that full mix. If it's a for-profit healthcare system like HCA, they try to go much more for that commercial population and shift their payer mix. It just shows how screwed up healthcare is. Like you just look at that and go, where does that make sense that, okay, we're going to go buy a car and we're going to negotiate 400% of the price for a certain segment of the population. We're going to sell that same car to other people. And then we're actually, for the very low end people, we're even going to sell it at a loss. Nobody does that, but that's healthcare. And then the spillover impact in so many other aspects. And so it is why I've at least been passionate to bring people like Rita to go, we've got to fix healthcare at a broader level. And then how you position hospice within that, we damn well better be at the table and be knowledgeable about the broader shift that's going to occur so we know how to position ourselves. And there are a lot of people, in fact, I'm going to call one out. AMGA is like, hey, just make end of life all of value-based care. I'm like, what? So I'm going to diss on that one, but it's a perfect example of if you're looking at just a small sliver and not looking at the broader context, we may end up in a place we don't want to be going forward.
This is such an interesting conversation. If we focus on the pricing piece, like you say, the different prices for a car, or in my own experience, the different pricing of medications, like how different, and we know that medications fall under the bundled payment for hospice. So if hospice A is paying $100 for a medication and hospice B is paying $10 for the same medication, how is that possible? But it is possible. And that whole discussion around pricing, not just of medications, but across healthcare is such a controversial issue because there's not that equity. There's not clearly defined, this medication costs $50. You're paying more and you're paying less. But we don't know what that baseline is. So the pricing is one thing. I think the other piece of this is the pendulum between mission and money. And, everybody needs to make money to keep their doors open. I get that. It's how far you go. Like, do we need a 50% profit margin in hospice because some hospices have that? Like, is that, and it's how we have that discussion, how we want to think about the financial realities of providing this care.
Yeah, I'm going to go there in a little bit. I've got a couple articles I'm going to call out to that. All right, well, I'm going to move along here, and I think you had a part in this one. The Hospice News 50, maybe I assumed you did, but last year at least you participated. Hospice News Provider Rankings and Annual Trends Report, the second annual Hospice News Provider Rankings and Trend Report. Basically, it ranked the hospices, the top 50, based upon revenue. In 2024, there were 6,685 companies that filed Medicare claims. That was up from 6,343, so an increase of about 20%. And the largest 15 providers of that report accounted for 20% of all hospice locations and 35% of hospice patients nationally. Now, at first blush, you may say, wow, those guys covered 20%. And this is where, and I know I'm going to get some calls from some of my for-profit friends. I'm looking forward to it, guys. Give me a call. But here's some things I'm going to call out. Software as an industry, their top 10 to 20 represent 50 to 80% of the total market. Banking, 50 to 75%, the top 10 to top 20. Accounting, the top 10 to 20 represent 70 to 90% of the total market. Okay, Comeaux, what's your point? We're still a very fragmented market. Well, then the private equity folks will say, that's why you guys need to be consolidated. Not so fast, mister. There's something about this model that's brilliant in the way it was designed. And I do think we're going into a very interesting time because of AI. A little bit of a rabbit trail. Jeff, our executive producer, has turned me on to the Diary of a CEO. So it's one of my favorite podcasts I listen to weekly. They had a really great podcast recently. He's really on the AI bent because he's like, I bring great people about health and wellness and kind of got that stuff figured out. Don't know where AI is going. So he brings these thought leaders on related to AI. And one of the folks was talking about, we're going into a place where probably the high performance organizations of the future might be the 10 to 20 small organizations that are very niched. Whereas in the past, because of knowledge, it was large corporations. So if the trend going forward is smaller, and guess what? Hospice has always been smaller because it's actually high touch. It's not high tech. And yes, we should utilize technology thoughtfully. Like when do you show up for an SIA, as Cordt was talking about earlier, when you're in those last 7 days of where you need more intensity. So I think it's a good thing. And hopefully that trend even becomes less, that it's more diffuse because you could bring more specialization, the call of high quality and where the future goes, and create great programs. And you don't have to create this huge consolidation to create interesting innovation. I am working on that. Keeping these small programs independent, but get them some of that leading edge thought process. So obviously I'm biased. I'm going to own it. And again, I look forward to my friends who are going to call me and take issue with what I'm saying. But I do think we live at an interesting crossroads where the past was, well, why would you become part of these large for-profit entities? Where are they going to bring all this great knowledge? I'm sorry, I actually know behind the scenes a lot of what they're working on ain't any different than what we're working on. There's no one that's figured out the perfect mousetrap related to hospice and palliative care. The for-profits are just a big marketing thing as far as I'm concerned. And now maybe they're like, oh, you don't know what we're working on behind the scenes. So please call me because I'd love to hear about that. So Cordt, what do you think?
I approached this particular article, and yes, this is the second year that Hospice Analytics has contributed to Hospice News story about the 50 largest hospice chains. And I approached this maybe from a little bit different angle, which is how incredibly difficult it is to identify hospice ownership. There are hospice chains, Vitas, for an example. Every Vitas hospice begins with the word Vitas. It's very easy. It's very clear. It's very transparent. I really appreciate that they make it very easy to aggregate all of the Vitas locations under one umbrella. LHC Group, as a different example, has a whole bunch of hospices across a whole bunch of states through mergers and acquisitions, and they've kept all of the local names. It's not LHC Arcadia, LHC Charleston. It's whatever the local name is. And that makes it very, very challenging to actually identify who that corporate owner is. And so I've been tracking this for probably 6 years now, tracking all of that merger acquisition activity in order to roll up CCNs to identify hospice chains. And I think going back to your early stats that you were talking about, very few chains account for an enormous amount of the field of the provision of hospice care nationally. And I think all of our independent providers need to remember that. So that when Medicare comes out with a rule change and they're like, oh, this is stupid, this is targeting me, it's not targeting you. Like, there is a target. There is a data-driven reason Medicare goes in the directions they go. No doubt about it. But that solo independent hospice provider in a small community or a large community, that is not representative of what hospice looks like from a national lens when Medicare looks at hospice. And to me, this is a reminder that we've got to have a clear understanding of how hospice fits into Medicare, into healthcare, into America. And often we focus on our specific niche of it when it's part of a very comprehensive system.
Well said. Yeah, makes it very complicated. All right, so another one. AMGA calls for total cost of care model for end-of-life care. So I didn't know about the AMGA, the American Medical Group Association, is that CMS, and basically came out and said CMS should establish a total cost of care model for end-of-life care. And so I read the article and I can see their perspective. So kind of picture a lot of primary care docs who are going to be more at risk for total, and they're basically lamenting the current model. This is where we've got to get very precise with our language. So I would push back and I'm like, first off, well, before I push back, I should step back and say, wait a minute, these are people referring. So why do they feel like the current system is broke? This is my read, is that the challenge quite often, right? We know because we lament this. We have to go in and have the tough conversation because they can't. We could, diss on them all day long. They have they have a huge patient panel, but that's what we're there for. It's the step in the gap, but the gap is what I feel like they're lamenting. So I feel like maybe if you took what they're recommending at face value, to me, it applies to the palliative care, serious illness space. And that be careful that what they're like, if someone just took it and ran to RFK and said, this is the answer, hospice could get wiped out. You erase that line of what hospice is today, which is still a brilliant model of healthcare. When reality is what I think they're speaking at is basically the gap before, the real palliative care gap. And I love that many of you listeners have seen the two triangles before, where it shows aggressive curative care and the triangle of palliative care, and you're getting a less aggressive curative and more palliative. And then you get that referral to the rectangle at the end, which is hospice. And then you got bereavement. And then there's more sophisticated models, but it's a great simplistic way to talk about that palliative care is in that concurrent care messiness space. And I think that is a space where we do need to see a lot of innovation. But if that innovation erases the line of hospice, and there's some well-known consultants out there would basically say, it needs to be innovated. Be careful innovation for innovation's sake. And like one of the examples is the landline versus the cell phone. I'm sorry. I still think that there's a lot of value in the hospice model. The election of the benefit, and that people are reconciling their own mortality and all of the hard work and how we walk alongside them. If you just erase that line and just make it, I have a friend who calls it the marshmallow or the blob, which is, again, what I kind of feel like this article is speaking to. And maybe most of those people just don't have the benefit of great hospice partners, and they just feel the weight of the burden of managing these complex panels. And so that's my opinion. It's a very strong opinion, a very well thought through opinion, one of which I've debated many people on this podcast and will continue into the future. But if I was king for the day, I would advocate you keep the hospice benefit. No, we shouldn't have 2 and 3 year length of stay. We've got to get better at that prognostication. And it really is more of a 6-month benefit, which, hopefully that's where we could apply technology. And you chassis it to innovations like a palliative care model, which needs to be funded different than it is today. And then maybe other innovations like PACE and home-based primary care. And that's the innovation space, chassis to one of the very original managed value-based models, which is called hospice, and has saved millions, if not billions of dollars. So be careful in the innovation that you actually don't kill. I've used the analogy before. Stephen Covey, the goose that lays the golden eggs, they killed the goose to open the golden egg to get all the eggs, and they didn't realize, oh my God, we killed the goose. It worries me that could be hospice in the look for innovation.
You raise a great point with it. To me, it's clearly articulating who's responsible for what. and identifying where those gaps are and filling them. Hospice fills many gaps from the acute care setting. Well, hospice has its gaps too. And how do we clearly set those expectations? Our healthcare system it's very fractured. It has a lot of growth to actually take care of patients, and I would expand that to the family members, the caregivers. There are many gaps, and this is one effort to identify and address some of them. But I completely agree with you, Chris. We need to be very thoughtful in the innovation that we're promoting. There are unintended consequences.
Well, those are all of mine for March. So I'm going to hit the last ones very quickly. So February just had a few, but this one really caught my attention because of you and I's predictions. This was the title: Existential Risk: Why Scientists Are Racing to Define Consciousness. As artificial intelligence continues to advance, ethical concerns grow alongside it. Scientists said the need to understand consciousness has reached a critical point. So if you remember, Cord, you and I talked about that in the beginning of the year of, we're going to have to answer, what does it mean to be human? Because if, basically they said once we hit AGI, they said this is a perfect analogy. I think it was in the Diary of a CEO. Picture an island with 14 billion geniuses all in the same place, and they could teach each other all at the same time. That's basically what we're headed towards. So then what does it really mean to be human? And if you remember, I theorized out loud, could we teach the AI to help us with advanced directives? Because at the same time, we're teaching the AI, please don't off us like Terminator, the movie. We embed John Connor in the system. So I just call out this article, was published in the Frontiers of Science. I think that's going to hopefully reach a bit of a crescendo. What does it mean to be human? I can't remember what podcast it was I was listening to, but music that's generated by AI, even art, there's something about the soul that comes out in things that we produce. Not that the AI produced things aren't good, but excellent things, you still feel that imprint. And I know it may sound wispy or whatever, or woo-woo, but you could tell the difference between a song that is just masterful compared to some produced by AI. And this reminds me, Cord, my mentor, Dr. Thayer, one of the last blogs he wrote, which is probably was 2016, I think somewhere in that ballpark, 2015, 2016, was, "Oh my, the robots are coming." And he said this: if your job can be replaced by a robot, it should. And what he was all about virtuosity and mastery, that if you are doing mastery, you can't be replaced by a robot. And that to me was a calling, and this is what I'm all about. My book, The Anatomy of Leadership, calling people to cause and purpose, I think is actually the answer to their question. People living in their purpose, as opposed to someone pushing the button of a job. I don't know what the hell my job does. I don't know what happens when I press this button, but they pay me for it. Unfortunately, that is a good portion of people's lives, and that is sad. That is what you want AI to produce or to replace. So what you do is maybe the only reason why you're on the face of this earth. And well, what is that? Hey, those are the things we should be wrestling with, and hopefully we're doing more of into the future.
This article and what you're describing, Chris, just reminds me. Yesterday, I popped into a virtual meeting of the University of Colorado palliative care team, and University of Colorado is where I began my professional career. And I thought, you know what, I want to go back. It was a review of the palliative care research they're working on. And I thought, I just want to tune in and see where they're at today, right? I'm so proud of the work that they're doing, and as an early member of helping support getting those efforts moving. It's amazing. So Gene Kuttner presented on the Ascent project, which is incredible.
We have a podcast coming out with Gene actually on that.
I'm excited for that. I think that's going to be just amazing. But then they talked about all these other research projects that the team is working on. And where I'm heading with this is they're very pragmatic and clinical and concrete and researchy, right? I found myself just kind of thinking about the ethical implications, going back to the whole, just because we can, should we be doing X, Y, and Z? And part of their research is addressing those ethical implications. And how do we define consciousness, and what does that mean? And I think that's a whole different conversation, and I'm glad that you highlighted this one, because it just brought up the ethical side for me to really dig deeper into why we're doing what we're doing. Is what we're doing the right thing? So I love that.
Don't miss part 2 of this episode, coming this Friday.